for the housekeeping. So
For
how
what
many
is that?
for the housekeeping?
Okay, you mean, okay. I'm not the one taking that. I think Dr. Tebe is taking
I
that.
know. I'm saying, how many minutes will your recap take? So that we
Recap
can.
is going to be less than 5 minutes. I'm not talking much on that.
All right, great.
We are going to be focusing more on what we are doing today. It's just to tell people we have done ABC last week, and now this is so that people, some people that will be joining us freshly today will not assume that we're just starting the webinar today.
All right, great. That's fine.
Yeah.
All right, that's perfect. We need to go live now. We are 4 minutes out. Please confirm that you're ready to
Amarachi?
go. Yes.
Daniel, you will start with the recap, or I will start with the housekeeping first. When I'm done with the agenda,
I think you should go first.
Yes.
I think you should go first.
You go
Yeah.
first and introduce Daniel for the recap.
So we're about to the welcome remark. We're not going to waste time on that.
There's no remark.
No, there's not. The welcome is just welcome. Thank you for attending this. That's okay.
So I thought I was in charge to read
no
speech.
No.
Read the speech.
That first one is just for the launching of the webinar, not for this today.
Thank you.
Yeah.
Thank you.
Oh, great. Are we ready to go, Gildas? Please, if you can give me host right. Felix, I see that you're there. Please say hi so that I know that we can hear you.
Hi.
Rachel, same for you. Please say hi so we know that we can hear you. Okay, moving on. All right, great. Thomas, I can see you. Please say hi so that we know that we can hear you.
Hi.
Great. I just saw Daniel. Dr. Elise, please, yes, go live. Thank you. Tablet, please share your screen and put it on the first slide.
Okay, hold on. I'll do that in a minute. I will share it. Okay, first slide. Okay. Can you see my screen? To make sure. Is it okay now?
Yes, Tablet, please just put it on the first slide and put it on slideshow just to inform us that the webinar has started. Yeah.
Sorry, colleague. I know we have just 1 minute. A very quick one. Dr. Elise, Kuta, please, you are welcome. Just to tell you that we didn't have your profile on time, and we apologize if you are not seeing your picture and names on this particular flyer. Please apology.
Daniel, we have participants here.
Yes.
We have
please
participants.
Go ahead.
We
All right,
have
please.
participants here.
Thank you.
I will take care of that, please. Thank you.
Tablet, please.
Can you see the full mode?
No. Please remove it from presenter's view.
Where about now?
No. Judas, please, if you can give me host right.
I made you co-host. Is that okay? Or I'll give you host rights and maybe ask you to give them back to me when they
Yeah, it's fine. It's fine, please. It's okay now. We have participants. Just give me whenever you're ready. So. Dr. Table, please start.
Okay, thank you very much, Amarachi. Good afternoon, dear colleagues, ladies and gentlemen. Welcome to this webinar It is a series of webinars on mpox, monkeypox used to be called, and still we can use that name as well. And this is the second session to ensure effective surveillance and laboratory investigation of mpox in the region. And the skill you're gonna learn today will serve for even for other regions if you have to work there, and it will show that you have experience and capacity as well and capability to deal with mpox. Today we have a really famous speaker, presenter, you know, Dr. Thomas Jung Nagbe. He was working in Liberia. He joined WHO as an epidemiologist, and he worked on several projects as the expert. He is with us. And we have Dr. Felix Olani Sani. For those who work on mpox, you know him. He was with us as well, working on mpox during the global outbreak. And we have Dr. Elise Pukaka, and she will speak. And even thought you're gonna see my colleague, Miss Rachel Achila, who was working on the lab, and but they will work together, but mainly Dr. Ellis will speak and about the laboratory part of it. So join me, please, to welcome them, and we will learn a lot from them today. Okay, but there are some rules for this webinar as the previous one as well, and the subsequent webinar. The general rule is we all need to note that this virtual training will adhere to the code of conduct to prevent harassment, including sexual harassment and power abuse or any behavior which is not allowed. And so, and those, if we adhere to this principle, it will help us in our career wherever we go, in any UN agency and even government agency, in our houses as well, and in community, because this is show self-respect, but we will adhere to that one. So if you have a concern, please do not insult the presenter or colleague, just address it in a professional manner, and we will answer the question. Now, on your screen, because you are all connected to Zoom, you will see some sign symbol around. We call them, for example, this bubble, the red one will be the chat. Then you will see a small hand, which in case you want to raise your hand for question and answer time, you can do that. And you can see this question and answer bubble. Mainly, this is for all of us. If we have a question, we will click on this one, you pose, you gave your question, you write your question. Presenter will be able, panelists, to write the answer here. This globe, I will come back to this, but having said that, for chat, this symbol, please do not use this one as for question. And because this is used for logistic purpose. In case you cannot connect or you cannot hear interpretation, please write it down here. For those who participated previously, you all know this rule. If we comply to it, it facilitates the work for everyone. Now, we will talk about the interpretation in a few seconds. Now, for interpretation, mainly this will be translate, and we have English, French, and for Portuguese as well. In case you don't get it very well, what you can still type in the question and answer. We will address it. But to be able for francophone, you can click on French, then you switch to that channel. For English speaker, you click on the English. For example, we have Dr. Elise, when she will speak and she present in French. For English speaking, you just click on English. Then you will hear it in French. If the translation is not what you think it is, for some who understand both language, you can raise that question in the chat and we will improve on it. But our translators are expert and they will always address this minor issue. So, and below note, please, this is nota bene for everyone, the interpretation of proceeding serve to facilitate communication, and it does not constitute an authentic or verbatim record of the proceeding. That means to protect us legally and to protect everyone. And for such a reason, really take it easy, please, colleague. And the translation, if it is not just exact as you think, at least to try to understand. Now, the live transcript will be available as well, but just it is here. If you want to know, you just click on this one, then you will see as the presenter present, you will see the word will come. But these are artificial intelligence systems. Sometimes it doesn't capture well the word. I encourage you to listen to the translation or to follow the presentation, because that's where you can grab some concept and add it to what you already know. And you can click on it to hide it when you need it. And that's here. But just focus on the presentation, please. Now, the recording and feedback, because we always been asked, can we get to this presentation? Can you share the presentation? Don't lose your focus, please. It is transparent. Everything will be recorded. And that's why we need to be very careful on what we say. And you need to give your consent. We ask your consent before a recording. And please, just if you don't want to be recorded, then you this is not really a place, because you don't give your consent to that. Whatever you're gonna say, we're gonna record it if you give question live. So now, and the record will be shared. After the presentation, our colleague Amarachi always email everyone. You will receive the professional email address to you only. And so with all the record and YouTube link, you can go over it. But when you receive it, if you want to download, please feel free to do it. And so the material, you receive those material. And as we always continue to improve our training program, and we need your support, really it is, we need it to improve on what we do and to please as well the audience and to deliver what really need to be delivered. Yeah, and a survey questionnaire might be shared with you at some time, point, and please take few minutes to give your opinion, a transparent opinion, so we can improve. But if you say this training is not good at all, you need to be able to comment to provide to propose a better way to do it. And so maybe one day you can join us as well to improve on this one. Yeah. Okay. Now, you have seen what this is the agenda today. We come back to that. We will hear soon from Dr. Daniel, who will do the recap. And even though you may not see here, but he has been with us for previous webinar, and he was leading it, and he will just tell you what we covered so far. And the next step for today, we will hear from Dr. Nagbe Thomas Nagbe, and Dr. Sunny. We will hear from them about this kind of a survey, about the surveillance, whether it is community-based surveillance, passive surveillance, sentinel surveillance, and active surveillance, you will know about it today, and how to establish, how to strengthen effective surveillance system with all the functions of surveillance and the characteristic and principle. You will know about that, and then you will know about the diagnostic aspect, how to diagnose and how to use laboratory testing, different laboratory techniques, how these tests are complementary, and whether they will talk about, you are concerned about the test validity or not, a colleague will cover all. Dr. Pukuta, Dr. Elise Pukuta, she will describe all those ones. Then we will have a question and answer session. As I say, please remember to put on the question and answer bubble label where you see, and this question will be addressed. And we will ask all the panelists to ask those questions. Questions which cannot be addressed today, they will work on it and share that information. At the end of the presentation, if you want to give live question, you raise your hand, you can put your camera on, the audience can see you, and you can really give your question live. And the colleague will will answer it. Our colleague, our incident manager, Dr. Walter Sadiq Solomon, is not will join us later with other colleagues, Dr. Kanu as well, to support this area. But we are here all, we work as one team, and I will pass the floor to my colleague, Dr. Daniel, to just, you have 5 minutes to talk, or less than 5 minutes, to brief colleague who just joined us today, and to highlight, to recap what was covered last session. Over to you, Daniel. Thank you.
Thank you so much, Dr. Teble, and welcome again to all our amiable participants today. Just to inform us that this webinar actually started last week, Tuesday, 23rd of April, 2024. And this is the second session, and out of the 5-week sessions that we will be having in this webinar. Just in a minute, just to tell you what we have covered last week, is that the first interactive session, very interesting. If you miss it, you can actually just check the recorded version. We dealt with standing recommendations on the mpox as issued by the Director General of WHO to all member states under the IHR 2005. And of course, we dealt with the strategic framework for enhancing control and achieving elimination of human-to-human transmission of mpox last week. And this was handled by our very erudite scholar at HQ, headquarters of WHO in Geneva. Now, the second section last week dealt with the monkeypox virus itself, where we discussed the overview of the virus itself, the taxonomy of the virus, and the genome structure. We had another presenter that day, very erudite scholar, Dr. Muteba Michel, and he gave us the overview. You can also access this in the recorded version. Then the third section that same day dealt with the epidemiology and the transmission of the mpox, and we dug deeper to know and understand the mpox outbreaks, the reservoir host, the modes of transmission, and the risk factors. This was co-presented by Dr. Diallo Momado and Dr. Michel Muteba that same day. Not to take our time, this is just to inform us that today marks the continuation of what we started last week, and each week was arranged to flow in conjunction with what was presented in the preceding week. So I wish all of us a very good webinar, and a knowledge-rich one that is going to capacitate us further to be able to respond well and holistically manage this disease in Africa and even globally at large. Thank you so much, and over.
Thank you very much, Dr. Daniel. Always nice to hear from you, and for the brilliant introduction and the recap as well. So as we say, if you miss any of these presentations, you can approach our colleague Amarachi here, who is really, and Mohammed. They work hard to supply all of the information to everyone because it is for knowledge purpose. Now we will move to Dr. Thomas and Dr. Felix so they can present on surveillance and reporting system. Surveillance is key to disease control and eradication. That's a sentence everyone need to keep at all time. Bad surveillance, there is no way you can say you eliminate or control. There are different methodology, and if you are interested, we can always talk about that. Now, Dr. Thomas and Dr. Felix, over to you. I will remove my slide. You can go ahead, please. You have 30 minutes, and I will put the timer. Thank you.
Thank you, Dr. Teble, and welcome our esteemed participants. I am Dr. Felix Sani. In collaboration with Dr. Thomas, we'll be talking about mpox surveillance and reporting. We're looking at effective surveillance and reporting mechanism. Here are the contents of our presentation this afternoon or morning, depending on where you are joining us. We look at the challenges of mpox surveillance in Africa, and we look at the major objectives of surveillance, including surveillance functions. We also look at the case definitions, as well as consider what we need to do in mpox surveillance, including reporting, case investigation, contact tracing, data management, as well as we'll link you to some of the tools for surveillance developed by the WHO, which is widely available for use globally. Let's start by looking at the challenges of mpox surveillance in Africa. I'm going to talk about three major areas that we have major challenges in mpox surveillance. I will talk about the surveillance itself. I will talk about case confirmation, as well as risk communication and community engagement. Let's look at the challenges one by one. The first challenge there is the limited understanding of epidemiological dynamics or transmission of mpox. In Africa, we don't have enough information to understand the dynamic of mpox transmission. So this made us, we have been advocating for research or more studies, particularly in endemic countries, to be able to understand who are the people involved, who are the groups, what are the modes of transmission, and to be able to know what are the dynamics. Another challenge is a low capacity for case detection, case investigation, contact tracing, as well as monitoring of suspected cases. I remember in 2022, we embarked on some missions to some countries when the outbreak was newly declared as a public health event of international concern. We discovered that in most cases, even when suspected cases are identified, monitoring is very, very, very low in some countries, probably due to low resources. Another thing is weak surveillance system, particularly at the point of entry. So we have been advocating for cross-border surveillance, particularly collaboration between countries. Due to the porous borders in Africa regions, we see a weak surveillance system at the point of entries. Another challenge for mpox surveillance in Africa is limited resources. I will not limit it to only limited human resources. We have both financial and human resources. Inadequate funding is a major challenge in Africa. So let's look at it. Another thing we have low rate of testing capacity. I will link this one to the next one, which in some areas, in some countries, particularly in hard-to-reach areas, for samples to get to the reference laboratories or approved testing centers, it takes a very long time. So this consequentially delay, in most cases, the confirmation of results of mpox cases. So due to this, we may see some delay in reporting, number one. Number two, we can see under-reporting as well. Also, risk communication and community engagement is low in terms of implementation, particularly in high-risk communities in the African region. Now, what are the goals of mpox surveillance? What are the objectives? I will give us the overall goal of mpox surveillance, and we look at 6 major objectives of the surveillance. The first and the overall goal is to eliminate human-to-human transmission. Number one, we want to stop this transmission. We want to protect people at risk. Also, we want to stop the transmission to new settings or new areas. If we remember in 2022, apart from the endemic areas, we discovered that monkeypox started spreading across the world until it was discovered, it was declared public health event of international concern. So the major focus of surveillance is to stop this transmission. Then let's look at the specific objectives. Number one of the objective of mpox surveillance is to rapidly identify cases, the groups involved, and this one will help us to prepare optimal care for the cases. The second objective is to isolate cases. When we identify cases early, we isolate them to prevent further transmission, particularly human-to-human transmission. Another objective is to identify, manage, and follow up contacts to recognize early signs of infection. I said it earlier that is one of the challenges. So one of the objectives of surveillance is to identify the contacts and to follow them up. In case if there are any signs of mpox infection, treatment can quickly be initiated. Also, to identify risk groups for infection and for severe disease. You know, in the last presentation, some of our presenters mentioned some key population group that are prone to mpox infection. So when this is identified, particularly in endemic areas in Africa, where we don't really understand the dynamic of transmission. So if we're able to identify the groups, we can quickly contain the spread of the outbreak. Also, to protect frontline health workers, this is very important because once a case is taken to the healthcare facility, the healthcare workers are at risk of being infected with mpox. And the last one is to prepare effective prevention measures. So as for surveillance system, we want to look at the core functions. There are about 5 major functions of a surveillance system. The first among them is case detection. For us to adequately respond to mpox outbreak in Africa and other parts of the world, the first thing for surveillance, the function of a surveillance, is to quickly detect cases. Dr. Thomas will talk about this further, but detecting cases need the use of definitions, that is of cases by WHO, as well as materials, that is tools, that like reporting materials, that is implementing immediate case-based reporting using updated forms designed by WHO. We'll share some of these forms with you at the end of this presentation. Another one is to investigate cases. This should be done rapidly. That is one of the functions of surveillance. And that should be done by the team of experts or trained individuals, which we also call rapid response teams. Another one is data analysis. without data analysis, we cannot take informed decisions. So it is good for us to know. Dr. Thomas, we talk more about this. What are the major focus of a data analysis? And the last one is to share information. Once we are able to detect the case, we fill up the reporting tools, we investigate the case, we do an analysis. Then the next thing is to share information so that the relevant stakeholders can have access, and this can inform interventions. So let's talk about standard case definitions. We will define suspected cases, we will define probable cases, we will define confirmed contacts, as well as when a case should be discarded. So it is important for us to look at this area because we have mentioned it initially that when you detect case, you need to use WHO standard definitions, and you need to use the tools developed by the WHO. Dr. Thomas will talk about it that when you discover a case, you need to report it immediately to the next level, and it must get to WHO. Then let's look at the definition of suspected cases. A suspected case of mpox can be identified in two major scenarios. I will talk about the two major scenarios. The first one, a suspected case is a person who has been in contact with a probable or confirmed case within 24 hours before exhibiting mpox symptoms. I will slowly talk about this. I said a suspected case is a person who has been in contact with a probable or confirmed mpox case within 24 days before showing signs and symptoms of mpox. What are these symptoms we are talking about? Number one, high fever, that a temperature above 38.5 degrees Celsius. Headache is another one. Muscle pain, back pain, or significant weakness or fatigue can also be all are parts of the symptoms exhibited by an mpox suspected case. The second scenario, we can also say a suspected case is a person who, since January 1st, 2022, exhibits an unexplained acute skin rash, mucosal lesions, as well as swollen lymph nodes. I don't need to put the picture of a skin rash here. I know we know skin rash, all of us, but I try to put pictures of a mucosal lesion as well as an anorectal lesion. So the rash may appear anywhere on the body. It may include anogenital area. It may be single or it may be multiple lesions. Also for mucosal lesions, that can occur in multiple areas. Can be eyes, can be mouth, can be rectal, it can be genitals or anus. For anorectal lesion, that may also present with inflammation, pain, or bleeding. In addition to that, when we have cases of rashes that cannot be explained by the common causes of skin problems, like chickenpox, shingles, measles, hives, or bacterial infection, as well as when you cannot link into sexually transmitted disease, and you have all these signs, all these symptoms I mentioned in the first and second scenarios, when you cannot link them to a particular cause of a skin problem, you can say the case is a suspected case. Now, let's also move on to probable case. What is a probable case? A person that exhibits an unexplained, number one, acute skin rash. And number two, mucosal lesion or swollen lymph nodes, which is also called lymphadenopathy. Please note that what we are saying, the skin rash we are talking about may appear as single or multiple lesion, including all these areas I mentioned when I was defining suspected cases. Now, mucosal lesion can also involve oral cavity, eye, conjunctiva, urethra, genital, that's such as penile or vagina, or anus, which we also call anorecta. The anorectal lesion might also present inflammation that is similar to what we saw in suspected cases. Now, how do we differentiate suspected cases from probable cases? If you still remember, I told you that if this person has been in contact with a suspected or probable case or confirmed case in the past 21 days and develop all those symptoms I mentioned, we can say the case is a suspected case. Or when the person develops skin rash or lesions that you cannot associate with the common causes of skin problems, we can call it a suspected case. But in case of a probable case, the person must exhibit acute skin rash or these lesions, mucosal lesion or swollen lymph node, which is one of the major difference between smallpox and mpox. Now, in addition to these two I mentioned, there are other 4 criteria, of which one or more of them must be met before we can classify that case as a probable case. One of them is that person probably have a link or contact with a probable or confirmed case in the past 21 days before the symptoms set in. Number 2, that person is identified as gay or bisexual or any of the cis or trans men that have sex with men. Number 3, that person has multiple sex or casual sex partners in the past 21 days. And the last one, probably that person has been tested for any of the autopoviral infections mentioned here, like MPV, specific PCR, or through sequencing confirmation. So we can see the difference between probable and the confirmed case now. Now, let's look at what a confirmed case is. I will not go more deep into this because we have the laboratory team that we explain. But once a case has been confirmed through PCR, that is polymerase chain reaction, or through sequencing, or both, we will say the case is a confirmed case. Now, when do we discuss the cases? A suspected case or probable case is considered discarded if laboratory testing of lesion fluid, skin specimen, or crusts using PCR or sequencing test negative for MPV. If it tests negative for monkeypox virus, so we will say we can discard it. That is when the laboratory tests are carried out, and the laboratory test must be carried out on lesions or skin specimens, and the result come out negative, we can discard it. Then let's look at the criteria for maintaining classification as a probable case. Though we are supposed to discard it, we still keep it as a probable case. If the probable case is retrospectively identified and lesion testing is no longer feasible, don't forget that I said initially that when the lesion is tested or skin specimen, if all of them are tested negative, you can call it a discarded. But if this is no longer available, but what is only available is just through other specimen tests, such as blood or any other one like that, you can't just say that it is negative. So if the person has been healed or if the person has recovered and the cross are falling off, you cannot just say the case can be discarded. Now, this is the major limitation for discarding the case. If the suspected or probable case, you cannot discard it solely based on negative result from oropharyngeal, anal, or rectal swab, or from blood test. So you need to test the lesion or skin specimen to confirm that the case can actually be discarded. Now, who are mpox contacts? So this way, let's go to this definition. A contact is an individual who has been exposed to an infected person during the infection period. If a person has been exposed to an mpox case during the infection period of the case, we call that person a contact. And this period begins with the first onset of the symptom, that is in the index case, and when the scabs are falling off completely. So from the time the case developed the symptom to the time the case is completely declared free of mpox, whoever gets in contact with any of them is considered an mpox contact. What are the types of contacts we need to look at? Number one, direct skin to skin or skin to mucosa physical contact, physical contact, such as touching, hugging, kissing, intimate, or sexual contact. Another type is a contact with contaminated materials, such as clothing or bedding. including materials dislodged from bedding or surface during handling of laundry or cleaning of contaminated rooms, or the materials that a case has used. Another one is prolonged face-to-face respiratory exposure to close proximity, that is to a case. Then also respiratory exposure can also be somebody that has contact with respiratory exposure or respiratory of the person or of a case. This includes inhalation, high mucosal exposure, or lesion materials, just as scabs, crusts, from an infected person. When the person is exposed to all this from an infected person, we say the person is a contact. Special consideration for health workers. We have special consideration for health workers. You know, I said it earlier that when the case is taken to healthcare facility, the first person that is at risk is a healthcare worker. So the exposure criteria also apply to healthcare workers who may be exposed in the absence of proper or appropriate personal protective equipment. That is why it is very important. We need to continue to lay emphasis on that when PPE is very important at all times. So I will stop here and allow Dr. Thomas to take it over from here. Thank you.
Yeah, thank you very much, Dr. Felix. Really, Dr. Felix Sani, and this is a great presentation. We will hear from Dr. Thomas as well. And in the meantime, colleague, please always use the question and answer. If you have a question, please type them. And if it is IT problem, and just use the chat. And so please fire your question as much as you can. And Dr. Felix, in the meantime, you think about an affected animal. If someone get in touch, whether it will be suspected or not, you will address that question from my side. And so, okay, over to you, Dr. Thomas. Thank you.
Thank you. Good afternoon, and thank you, Dr. Felix, for the splendid presentation. Good afternoon from wherever you are. In Brazzaville, and it's in the afternoon hours. To continue this presentation, let us first consider what are the surveillance considerations for mpox. On account of the transmissibility, exposure factor, risks, and other public health risks, most countries have considered a single case of mpox as an outbreak, especially so in setting that mpox is non-endemic. Countries can redefine outbreak based on the frequency of the cases and the burden of the disease itself. On account of the IHR Article 6, the standing recommendation by the RD in August 2023, and the most recent communique in a meeting that was held in Kinshasa, for some of you that were there, there has been repeated call and resounding call to ensure that countries report mpox cases to WHO, including minimum data sets of epidemiological relevance. This is extremely important for us at this end. It is also important to note that mpox is case-based surveillance. And so it has clear case definition as alluded to, as presented by Dr. Felix, and health facility, point of entry, and community are all the different tiers .
I think, Thomas, you may have some connection problem.
The system hugely depends on event-based surveillance to detect alerts or signals, and that can be verified, and investigation can be conducted. Next slide, please. in reference to establishing alert management for mpox, this is aimed at systematically to manage and monitor alerts and report cases effectively and promptly. There is a need to establish an alert management system that ensures that reports are received. Event-based surveillance are strengthened because this is extremely important, especially so in non-endemic areas where the signs and symptoms might mimic the other cases that we've spoken about, either chickenpox or measles or something of the sort. And alerts need to be investigated and verified, and information needs to be validated before, all right, they are properly investigated and then follow up. Next slide. This is an attempt to provide an algorithm that countries can further improve on. If you look at some of the source, the resource information sources at the lower level, we include community leaders, heads of families, person with symptoms. Other resource persons could be traditional healers, religious facilities, and a lot more. Okay, these are areas that you might receive signals or alerts that could further be verified, maybe from the health facilities. I'm quite sure each country has a different structure in reporting from all the different tiers of service delivery. As you will, for instance, in Liberia, you will have gotten alerts from the community that can be verified by the proximal health facilities, and then investigation can initiate from that level, and then to the once it is confirmed, samples are picked up, confirmed, and then it's elevated to the next level. Next slide. Next slide. Let us talk a little bit about case investigation. This is extremely important because it allows us to be able to characterize the illicit source, the mode of transmission pattern, exposure factors, and those vulnerable groups that are at risk. And so it is important that surveillance officers and epidemiologists that are conducting case investigation has to consider interviewing patients, caregivers, healthcare workers with the including clinical assessments of the patient, complete case reporting. In fact, we've annexed a sample of the case reporting, including links to the full detailed case investigation form. As stated in the beginning of the presentation, one of the challenges we are faced with at the moment is getting adequate details in terms of case investigation from countries. So it's important that we take a look at the case reporting form, the detailed investigation form, and see all the variables that are being requested while you are investigating. Make sure you are able to carry out exposure investigation. This should be 21 days prior to symptoms. Construct a line list and update with new information, and conduct active case search in order to be able to identify and list adequate number of contacts. Next slide. So this is just a synopsis of the minimum required data information that can be collected using the form that we've talked about, the case reporting form. It includes the date of diagnosis, identification, sex, all the demographic of the patient, healthcare, medical history, including pregnancy, immunosuppressed situations, clinical signs and symptoms, hospital admission, intensive care unit if this patient went through that process, the recent travel history, contact with animals, mode of transmission, the clade and genomic characterization, if available. I'm quite sure there are some countries that might have the capacity to do PCR, but don't have the capacity to do the sequencing and the rest of it. And then, of course, the outcome of the case. Next slide. In the interest of time, maybe you might realize that I'm going a little bit faster, but please let me know through your questions or so that you might ask in a Q&A for clarity in any points that you did not get clearly. However, it is also important to understand that in order to consider as you evaluate mpox outbreak, there are key elements to consider. One, the baseline number of cases exceeding the baseline, a localized increase in number of cases, cluster of cases linked to gathering or events, changes in disease dynamics, monitoring of viral evolution, vulnerability of affected population, and of course, the public health response and availability of countermeasures capacity in the country. Next slide. Dr. Felix have introduced contact tracing, but it's important to understand that with effective contact tracing, we are capable of interrupting transmission chain and facilitate early case detection and reduce severity in the disease. Because once you are able to pick up the case early, we can be able to isolate such a case and initiate prompt case management. So in other words, it is expected that we have to interview cases and then identify and list all contacts, the attendance list, passenger manifest, if the index case had moved, from one end to another, can be used to identify contacts. Some patients may be hesitant to provide all contacts, but again, it's dependent on how you are able to encourage such a case to give all the full detail. Remember, a lot of these infectious diseases, speed and precision is extremely important to interrupt transmission. So gathering information on all the contacts and effectively monitoring and tracing them could prove useful in interrupting transmission as soon as possible. Notify contacts within 24 hours of identification and start effective monitoring. The monitoring of contacts should go for 21 days from the last exposure. Quarantine or exclusion from work are not necessary for asymptomatic, especially note this, asymptomatic contacts. Next slide. We thought to include some of the elements that can be considered in data management and reporting. One of them include ensuring that you have the requisite people that are collecting data, that are conducting investigation in the field, and that are also included within the response. This will include epidemiologists, surveillance officers, data manager, HMIS officer, record officers, data clerk, and the rest of it. And perhaps as you go lower, there are other cadets that might be doing other significant functions as well. Ensure that all data collection and reporting tools are disseminated to all reporting facilities. Case reporting form, line list template, contact listing, and all follow-up form are ready. Establish mpox outbreak database to collect reports from all reporting facilities. Be reminded that in data analysis, person, place, and time analysis are critical in in mpox analysis. Next slide. Okay, so what are some of the information products for mpox surveillance? Of course, for a lot of the countries and given the public health breaks to mpox, mpox has now been included in the active surveillance in many of the countries, if not all of them. And as such, there is a need to include mpox in your weekly epidemiological bulletin. And of course, in the event you have an outbreak, you've declared an outbreak, or you've confirmed a case, there is a need to begin to produce situational reports, and occasionally see if you're able to produce additional articles or quarterly bulletins, considering all the key monitoring indicators. Case report form of all probable and confirmed cases are extremely important to be considered. Update and consolidate all line lists, because some of the key variables that we are talking about, additional data that could be needed from the WHO, will come from the line list and case investigation reports as well. So these are all the key information products that are extremely important in reference to mpox reporting and documentation. Next slide. So in reference to monitoring, we want you to take into consideration timeliness of receipt of cases from each of the different levels, completeness, proportion of suspected outbreaks investigated, proportion of suspected cases with laboratory tests performed, time from specimen collection to receipt of specimens in the lab, time from receipt of specimen in the laboratory to provision of results to appropriate authorities, proportion of confirmed and probable cases with complete demographic information, and finally, proportion of confirmed and probable cases with complete clinical and risk factor information. Next slide. Dear colleagues, it is important to end with these final messages as a summary to the presentations we've just given. One, it's important to note that effective surveillance of mpox as a prerequisite for early case detection, interrupting and transmission chain, and outbreak control is extremely important. Community participation engagement is essential for successful surveillance and response to mpox. Involvement of private sector is paramount. Building the capacity of healthcare providers and community workers of mpox surveillance prevention management cannot be overemphasized. Support to mpox alert, case investigation and contact tracing, support mpox sample collection and transportation, strengthen national reference laboratories for PCR capacity and sequencing, support mpox case management and prevention, and strengthening RCCE on mpox in high risk, especially in high risk communities, is also extremely important. Finally, we've also shared in the following slides, next slide, some of the key reference instruments or documents that can support surveillance, case investigation, and contact tracing for mpox. The most recent interim guidance on surveillance was released in 2024. You can easily find that on online. We've attached all the links, including the management guidelines for management of mpox diseases, the technical guideline on integrated disease and surveillance I'm quite sure all of you in your respective countries within the region have adopted this guideline. And of course, the new version of the mpox surveillance guide. Other instruments to include is the, next slide, is the toolbox, the WHO outbreak toolbox. You will be able to access a lot more reference instrument that could help with reference to disease surveillance for mpox, the epidemiology of mpox, case management, vaccine, and the rest of it. Next slide. Yeah. So thank you ever so much. I will stop here and then we will entertain questions.
Great presentation, Dr. Thomas and Dr. Felix. And thank you very much for the brilliant joint presentation. And colleague, please use the question and answer chat box. And we have seen some questions there. And panelists, please look at those questions. And I even shared some with you already. And other question in the same chat will be addressed by our colleague, Dr. Elise, and back up by Rachel as well. Dr. Thomas, this will be for you as well. I have seen you have covered very well the surveillance for human part, where you talk about a person, you forgot about animal again, and you were member of the National Bridging Workshop, which was just to strengthen the collaboration between human and animal health sectors. So you think about sentinel surveillance in animal, how we can really come up with powerful surveillance tool and on investigation form. Okay, now we move to Dr. Ellis, please, over to you. Okay, the question and answer time will come, so you can address this one. Thank you very much. Over to you. Yeah. Okay, slide mode, please. Okay. We have Dr. Pukuta, Elise.
Just before she comes on.
Yeah, okay.
Thank you. Thank you, Dr. Elise Pukuta, for accepting this to do this presentation. Dr. Elise is from INRB in DRC, and she has a long time experience with working with mpox and other epidemics. So she'll be giving us the country experience as she explains to us the different techniques that can be used. Over to you, Dr. Elise.
Merci pour la parole. Nous allons parler du diagnostic du mpox. Oui.
Okay, I was just going to say for a colleague who speaks English, you can click on the interpretation in English. You should be able to hear the translation. In case there is any problem, please highlight it. Over to you. Thank you very much. Welcome again.
Nous allons parler du diagnostic proprement dit du mpox, qui est anciennement appelé la variole de singe, le processus qui se passe au laboratoire, et on parlera plus précisément de la réaction en chaîne de la polymérase, qui est la PCR, la technique principale que nous utilisons pour le diagnostic. Dia, s'il vous plaît. Oui, on peut passer. On peut évoluer, s'il vous plaît. Prochain dia. On nous l'a dit, un petit rappel, nous savons que le mpox, c'est une zoonose qui est due à un orthopox virus et il est de la famille des poxviridae. C'est une zoonose qu'on rencontre principalement dans les forêts tropicales humides de l'Afrique centrale et de l'Afrique occidentale. Et il y a d'autres orthopox virus, tels que le virus de la variole, le virus de la vaccine, variole bovine. Et leur réservoir jusqu'à ce jour n'est pas clair parce que les primates qui étaient considérés comme réservoirs tombent aussi malades comme les humains. Et les recherches se poursuivent pour parvenir à détecter le réservoir du virus. Et comme je l'avais dit, il est endémique dans les régions forestières de la RDC. Donc, c'est une maladie qui est sous surveillance à notification obligatoire en RDC. Et en RDC, c'est le clade 1 qui circule principalement. Oui. Dia, s'il vous plaît. Ça, c'est pour donner l'idée de la circulation du virus chez nous, parce que le labo a commencé à fonctionner formellement depuis 2010. On peut voir qu'au départ, c'était vraiment concentré dans les régions forestières. Comme on peut le voir, de 2010 à 2015, le virus était principalement dans les régions forestières du pays. Oui. Et après 2015... Oui, Dia, s'il vous plaît. En 2016, en 2017, en 2018, c'est toujours à peu près le même scénario. C'est dans les mêmes provinces qu'on retrouvait pratiquement le virus. Et ça, ce sont les provinces des régions forestières du pays. 2016, 2017, 2018, 2019, 2020, 2021. Oui. Dia, s'il vous plaît. Euh, 2022, à partir de 2023, on a commencé à retrouver le virus aussi dans d'autres zones qui n'étaient pas endémiques dans le temps, notamment dans la ville de Kinshasa et puis au sud Kivu, où dans le temps, on n'avait jamais eu des cas positifs, mais on a commencé à avoir des cas positifs qui sont principalement des cas importés des provinces endémiques. Oui. En 2022 et 2023, on peut continuer. 2023, comme on peut le voir ici, ça paraît plus facilement. C'est presque tout le pays maintenant qui a eu des cas positifs de mpox. Donc, ça s'est vraiment éparpillé dans tout le pays, dans presque tout le pays. Et en 2024, ça continue. On voit le Sud Kivu qui n'avait jamais eu de cas, mais aujourd'hui, il y a une grosse épidémie au Sud Kivu. Dia, s'il vous plaît. Nous allons parler à présent, proprement parler du diagnostic du laboratoire, toutes les étapes qu'il nous faut pour faire ce diagnostic de laboratoire. Yeah. La méthode principale utilisée au laboratoire, c'est le test d'amplification de l'acide nucléique. Nous amplifions l'acide nucléique. Le test que nous faisons, c'est par la RT-PCR, c'est-à-dire la PCR à temps réel. Nous recherchons l'orthopox, mais nous faisons aussi un diagnostic différentiel pour détecter des cas de varicelle, parce que surtout dans les cas de varicelle graves, ça peut prêter à confusion sur terrain. On peut faire la confusion entre des cas de mpox et des cas de varicelle. C'est pour cela que nous l'avons inclus dans notre algorithme. Et nous faisons aussi la détection du clade pour savoir si c'est un clade 1 ou clade 2, c'est par la RT-PCR toujours. Il y a aussi le diagnostic moléculaire par GNexpert qui peut se faire. Il y a la sérologie. Mais la sérologie, c'est surtout dans les enquêtes sérologiques pour pouvoir détecter des provinces là où les milieux où le virus circule. Et tous les échantillons positifs, on fait le séquençage des échantillons positifs. Cela permet de soutenir les activités de surveillance et pour savoir le virus, il vient d'où, il est lié à quoi. Et toutes les manipulations sont effectuées dans des installations de confinement. Dia. Mais la première étape, c'est le prélèvement des échantillons. Pour un diagnostic de laboratoire, le prélèvement des échantillons, c'est une étape capitale parce qu'il faut prélever le bon prélèvement, savoir quoi prélever, quand prélever. Les différents échantillons qu'on peut prélever, nous avons le sang total qui peut être soit sur EDTA ou bien sur tube sec, mais c'est surtout utilisé pour les enquêtes sérologiques. Parce que le sang total, on peut aussi faire la PCR avec le sang total, notamment le sang prélevé sur EDTA. Et le grand problème est que la virémie ne fait qu'une dizaine de jours. Et si on prélève après la virémie et qu'on se contente simplement du sang, on peut avoir des résultats erronés, faussement négatifs, alors que le sang a été prélevé après la virémie. On prélève aussi des écouvillons, des liquides de vésicule, de pustules. On peut faire un écouvillon oropharyngé et on prélève aussi les croûtes. Nous avons le modèle ici, nous avons un écouvillon, nous avons un scalpel qui peut aider à récolter les croûtes et les croûtes sont mises dans des tubes avec vis qui ferment très bien. Ça permet le bon transport de ces échantillons-là. Pour le prélèvement des différents échantillons, nous avons le liquide de la lésion. Pour faire ce prélèvement-là, il faut désinfecter la lésion avec une lingette alcoolisée. Ensuite, on va avec un scalpel ou bien une aiguille, on va ouvrir la pustule. On voit les exemples de pustules là qui sont là bien des pustules. On va ouvrir et puis recueillir le liquide avec un écouvillon stérile. Et ensuite, on va remettre l'écouvillon dans notre tube original et qu'on pourra envoyer au laboratoire. Oui. Prélèvement de croûtes. Les croûtes, c'est quand les croûtes, on va aussi désinfecter. Ensuite, on va détacher, soit avec une aiguille, on va détacher simplement. Ces croûtes-là, ce sont des peaux qui ont séché. On va mettre dans ces tubes-là des cryoviales, qui sont des tubes, des petits tubes qui ferment très bien et qui peuvent être transportés au laboratoire. Les vésicules et les croûtes, donc les liquides des vésicules et les croûtes sont des échantillons. Quand on fait la formation, on dit toujours au personnel de santé que ce sont les meilleurs échantillons parce qu'ils sont très, très riches en virus. On ne peut pas rater le diagnostic quand quelqu'un est positif avec les écouvillons, les liquides de vésicule et les croûtes. Oui. Transporter les échantillons au laboratoire correctement parce que toutes les étapes sont très importantes pour avoir de bons résultats. Si on a fait un bon prélèvement et que les échantillons ne sont pas bien conservés, bien transportés, ça peut biaiser le résultat. C'est pour cela qu'il est très important de bien transporter les échantillons. Avec le système de triple emballage, les échantillons seront bien protégés et bien transportés au laboratoire où il faudra effectuer les analyses. Yeah. La deuxième étape, c'est l'extraction de l'ADN. Le virus mpox, c'est un virus ADN. C'est pour cela, pour faire la PCR, la première étape, c'est l'extraction de cet ADN-là. Oui. Et la biologie moléculaire, on le sait, a considérablement modifié le diagnostic de routine. Avec la biologie moléculaire, on peut détecter l'ADN ou l'ARN de quelque chose. Pour notre cas, c'est le mpox. On peut détecter l'ADN du virus sans aucun problème. Le principe de l'extraction, ici, c'est le modèle. On peut revenir à la précédente dia, s'il vous plaît. Oui, on passe. Ce qui suit, la dia qui suit. OK, on peut. Bon, ici, c'est le modèle de kit d'extraction. La procédure des extractions, il existe plusieurs méthodes d'extraction. On a des extractions avec colonne de matrice de silice, extraction avec billes magnétique. Nous utilisons l'extraction avec colonne de matrice de silice et pour la purification de l'ADN. Oui, on peut passer. Et après avoir extrait, nous allons maintenant passer à l'étape de la PCR à temps réel. Oui. L'algorithme que nous utilisons pour la détection de la variole de singe à l'INRB, donc dans mon laboratoire, nous faisons, quand nous avons notre ADN, nous faisons d'abord la PCR à temps réel pour détecter l'orthopox virus, parce que le mpox, c'est un orthopox virus. Quand l'orthopox virus le test est positif, nous allons faire la détection du TLAD pour savoir s'il est du TLAD 1 ou du TLAD 2. Quand ici c'est positif, on va partager les résultats avec le ministère de la Santé et tous les partenaires impliqués, mais aussi on envoie au laboratoire de génomique pathogène pour le séquençage. Et quand il est négatif, on fait un diagnostic différentiel. Nous recherchons le virus de la varicelle. Et que ce soit positif ou négatif, on partage nos résultats avec tous ceux qui ont droit à voir le résultat. OK? Quand nous avons l'échantillon au laboratoire, la première étape, c'est de vérifier si l'échantillon que nous avons correspond au formulaire, parce que les échantillons, quand on envoie les échantillons au laboratoire, ils doivent toujours être accompagnés d'un formulaire. Nous vérifions si les informations qui sont sur les échantillons correspondent au formulaire. Si c'est oui, on va attribuer un numéro de laboratoire. En présence des croûtes, on va prendre un morceau de croûte. S'il y a plusieurs morceaux, si un seul, on va prendre le croûte là, qu'on va mettre dans un cryotube et nous ajoutons 1500 microlitres de PBS. On va mélanger au vortex. Ensuite, on laisse reposer toute une nuit à plus 4 degrés et on fait l'extraction le lendemain. OK. Prochain dia. Si nous avons reçu un écouvillon, le liquide de lésion ou bien un écouvillon nasopharyngé ou oropharyngé, nous, dans un cryotube, on va casser la partie qui contient l'écouvillon avec des ciseaux. On va ajouter 1500 microlitres encore de PBS. On mélange avec le vortex et ensuite, on va reposer encore toute une nuit. Et le surnageant là sera utilisé pour l'extraction de l'ADN viral. OK. Prochain dia. Après l'extraction de l'ADN viral, nous allons procéder au test de la PCR à temps réel pour la recherche des orthopox. Comme nous l'avons dit, s'il est positif, c'est-à-dire quand le CT est inférieur à 37 dans une province endémique, nous recherchons le TLAD. Pourquoi on se limite aux provinces non endémiques? Parce que nous avons tellement beaucoup de positifs dans les provinces endémique, donc c'est pas tout le temps qu'on fait le CLAD là. Quand il est négatif, on fait le diagnostic différentiel et les positifs sont envoyés au laboratoire pour le séquençage. Les résultats, comme on l'avait dit, est partagé à tous les partenaires impliqués dans la surveillance dans notre pays. Prochain dia. Et la PCR, en bref, la PCR a 3 étapes. Quand nous avons notre ADN, la première étape, c'est la dénaturation. La deuxième étape, c'est l'hybridation. La troisième étape, c'est l'élongation. Dans l'étape de la dénaturation, parce que les différentes étapes se passent à des températures différentes. Avec la dénaturation, nous avons l'ADN qui est une molécule à 2 brins et qui va se séparer. Les 2 brins vont se séparer. Ensuite, il y a l'hybridation parce que quand nous faisons la PCR, on met tous les réactifs nécessaires, notamment les amorces et les ions et tout ce qui permettent à l'ADN de se répliquer. Et nous avons les amorces qui se fixent au brin d'ADN parce qu'au début, on avait 2 brins et les 2 brins se séparent et chaque brin va se lier, l'amorce va se lier à chaque extrémité des 2 brins. Nous aurons 2 molécules. De 2 molécules, on en aura 4, ainsi de suite. Et cette amplification-là, c'est une augmentation exponentielle. Et cette augmentation-là exponentielle pourra être vue maintenant avec la PCR en temps réel. On peut le suivre, on voit comment est-ce que ça progresse. Et à la fin de la PCR, on voit les positifs avec des courbes bien précises. On sait dire que là, c'est positif ou là, c'est négatif. Oui. Et comme on a dit, c'est l'amplification de l'ADN et la quantité d'ADN double après chaque cycle. Et ça dépend maintenant d'un fabricant à l'autre du kit pour le nombre de cycles. On peut avoir 35 cycles, 40, d'autres vont à 45 cycles. Et ça permet maintenant, après N cycles, il y aura 2 exposants N fois plus d'ADN parce que c'est une augmentation exponentielle. Donc, quand on a, on a des milliers d'ADN à la fin de cycle et ça permet maintenant de visualiser notre réaction. Oui. Quand nous avons fait notre PCR, il faut toujours, il y a la gestion des déchets, qui est une étape très importante au laboratoire. Les déchets infectieux du mpox, ils doivent être désinfectés avant d'être éliminés. Donc, on fait une désinfection chimique d'abord. Nous avons un désinfectant, on met en contact tous les déchets avec le désinfectant chimique. Ensuite, on va autoclaver, on va passer ça dans l'autoclave. L'autoclave, c'est une élimination avec la chaleur humide. L'autoclave, ça nous fait au moins 120 degrés, donc ça nous permet d'éliminer les déchets et ensuite ces déchets-là pourront sortir du laboratoire pour être incinérés. C'est comme ça que nous gérons les déchets parce que c'est aussi une étape très importante. Il ne faut pas que le laboratoire soit à l'origine d'une infection dans la ville. Oui. Ensuite, oui, prochain dia. L'hygiène des mains aussi, c'est très important. Avant de porter les équipements de protection, on doit se laver les mains. Après avoir travaillé, enlever les équipements de protection, il faut aussi se laver les mains. Donc, le laboratoire ne peut jamais manquer de l'eau courante, du savon pour se laver les mains. Oui. Prochain dia. L'utilisation correcte des équipements de protection individuelle aussi est très, très important. Il y a les gants, il y a la blouse de laboratoire, avec le masque que nous portons régulièrement. Il faut savoir les porter, mais il faut aussi savoir les enlever parce que après avoir travaillé, notamment les gants sont souillés, il faut bien désinfecter les gants, ensuite les enlever, parce que c'est aussi une étape à laquelle quelqu'un peut se contaminer au laboratoire. C'est pour ça qu'il faut bien maîtriser l'utilisation correcte des équipements de protection individuelle et ne jamais travailler au laboratoire sans équipement de protection individuelle. Prochain dia, je crois que c'est fini, si je ne me trompe pas. Merci de votre attention.
Wow, très bien. Merci beaucoup, docteur Elisa Pokota. Excellente présentation. Donc, certainement, vous connaissez professeur Placide et
Oui.
docteur Massimo aussi, professeur Massimo et
Oui.
professeur Mouyambe.
Ah, c'est notre boss.
Oui, donc parfait. Non, c'était une très belle présentation. Chers collègues, nous vous encourageons encore à envoyer vos questions et réponses. On va passer à cette session maintenant. Donc, pour vous, professeur Pukota, vous savez très bien, vous l'avez dit, que c'est une zoonose. Donc, mais souvent, il se peut que il y a des problèmes de tests. Par exemple, si le secteur vétérinaire a des tests et que vous, c'est déjà épuisé, est-ce que vous prenez là-bas ou est-ce que vous échangez? Donc, ça, vraiment, on aimerait savoir ça. Et en plus, si vous regardez très bien pour le real-time PCR, et c'est vrai, les amorces se collent, mais souvent, il y a un problème. Donc, ces amorces-là, ça ne se passe pas comme ça ne se colle pas. Et l'amplification ne peut pas avoir lieu, même si le test est positif. Donc, certainement, il y a des collègues qui veulent savoir ça. Parce que ça, c'est des manipulations qu'il faut vraiment avoir l'expérience et puis suivre un protocole bien décrit aussi. Donc, peut-être vous allez nous parler de ça tout à l'heure. Donc, OK, merci beaucoup. Donc, vous pouvez regarder les questions et puis on va passer aux questions et réponses. Docteur Daniel est avec nous? Oui. OK. Chers collègues, vous pouvez, ceux qui veulent parler directement et live, donc vous pouvez soulever vos mains en utilisant la main, le signe de la main. Donc, pour que vous preniez, on vous donne le micro. Et sinon, on peut commencer déjà à répondre à ces questions. Rachel, over to you, please.
Okay, thank you. I'd like maybe the questions for lab. From the Q&A, most of them are in French, so I'm sure Dr. Elise will be able to pick them very quickly. So you want us to do live answers or?
If those who want really to take the floor, they can raise their hand using the icon hand, where you see your small hand. You can just click on that one, then we will give you the floor. Otherwise, we can move on with the question and answer with panelists straight, before closing time. Thank you very much.
Dr. Tieple, we have 3 hands raised.
Ah, great. Can you give them the floor, please? Because I cannot see the hand.
Yes, I already gave them.
Yeah.
Dr. Alan Mouzaka, could you please take the floor?
Merci, c'est Alain Moussaka depuis Kinshasa en RDC. Ma question s'adresse à Dr. Elise qui a parlé du diagnostic. Je voudrais savoir, aujourd'hui, la RDC parmi les États qui notifient beaucoup de cas. Et je pense que si je ne me trompe pas, dans la situation épidémiologique du pays, environ 15 à 20 provinces sont touchées sur les 26. Est-ce que à l'heure actuelle, les diagnostics peuvent être posés ou un diagnostic de présomption peut-il être posé avec des tests rapides qui puissent aider les provinces et les zones de santé reculées lorsqu'ils ont des cas qui répondent à la définition des cas suspects, ne fût-ce qu'un test rapide qui puisse aider à orienter les diagnostics pour une meilleure prise en charge. Et si tel n'est pas le cas, y a-t-il des avancées et elle qui est au niveau de la virologie, y a-t-il des avancées pour avoir au point ne fût-ce qu'un test rapide qui puisse aider dans ce contexte-là? Merci.
Docteur Tibli, est-ce qu'on collecte toutes les questions et ensuite on répond ou bien
Oui.
on répond?
Merci beaucoup. On collecte deux ou trois questions et puis on va répondre à ça. Est-ce qu'il y a
Ok.
d'autres questions au labo?
Oui, docteur Sumo Nuolo, please take the floor.
Yeah, thank you very much. Yes, thank you very much. My name is Sumo Nuola from Liberia, the mpox focal point at the National Public Health Institute. My question goes to the case investigation presentation to Dr. Thomas Nangbe. One, the case investigation form that we are using in Liberia, it doesn't have anything that has to do with One Health. Is it possible that the WHO Africa region can see reason to update those forms and make it user-friendly by including One Health into it? That's one. Two, we have reported a number of cases, most especially for this year. And there are other places we assume that cases are coming from, but because people are not aware, people haven't seen what it is when you say monkeypox or mpox. Is it possible for the WHO to support the country in producing more posters or leaflets or flyers so that people can be aware, so that people can exactly, when you say mpox, that will help the surveillance officer to report the cases. So it helps the case investigation or the case investigator to report more of the cases, because the community will now see reason because whenever you see the poster, you know exactly, okay, this is mpox. Anybody you see with this kind of or signs or symptoms on them, you know exactly it's mpox. You can quickly report that to the nearest health facility. Can WHO or African region support the countries in producing more posters or leaflets? That's two. My next question is not just to Mr. Thomas Nami, but we had a meeting a few weeks ago in Kinshasa, Africa CDC. Now we have understood that in that meeting, we understood that most of the cases are under 15. Is it possible for the WHO Africa region to see reason to vaccinate all, because there are 10 countries now they are reporting for now? Is it possible for the WHO Africa region to vaccinate all children under 15 years? Those are my questions. Thank you very much.
Dr. Sumo, great question. Thank you. Nice to meet you again. So these are three questions here, and one question from DRC, and well, we can make it two. Then the third one, Mohamed, please, so we can move to the answer.
Docteur André Désiré, prenez la parole, s'il vous plaît. Docteur André Désiré, s'il vous plaît, activez votre microphone. Ok, je pense que ça sera tout.
Ouais. Okay. Rachel, your hand is up.
Yes, I'm waiting to answer.
Okay. Yeah. So you're in a hurry, but it's okay. Okay. Damini, you know the answer of the question, please. Mohamed, we go for the answer now, please.
We have someone who just raised his hand.
Yeah, who's that?
Dr. Hassan Saware,
Okay.
please take the
Hassan
floor.
Saware. Yeah, then that will be, yes. Thank you.
Yes, good evening from Beijing, China. I'm Hassan Soare from Sierra Leone, but presently in China. So my question is based on the WHO Africa region statistics, how many countries do we still have or are still reporting confirmed cases of monkeypox? And among these countries, how many of them have the testing capability to actually confirm monkeypox in their country? Because from my point of view, if we want to eliminate or eradicate monkeypox in those regions, they should be able to test and confirm their own cases so as to ease, one, the transmission route, and then two, to also protect other neighboring countries who are not reporting cases. But if these countries that are still registering confirmed cases don't have the capability to confirm their own cases, except they have to transport sample or specimen to another country to be confirmed. So how are we going to eradicate monkeypox in the continent as a whole? That's my question.
Thank you, Hassan. Great question. Always nice to hear from you as well. Okay, now, Rachel, we move to the answer. Not much left in 3-4 minutes. And then after we will add some extra information. Over to you, Rachel, please.
Yes, and I will also request Dr. Elise to be ready to complement. But just the question on use of RDTs, this was from the WHO guidelines. They were being tested and they were found to be possible to be used, but in remote areas. But you have to be very, very careful. Again, you know, RDTs are not as sensitive as the PCR. So when you use the additive, it's still best to carry the sample for further confirmation at the national labs. So it can be used at the remote peripheral areas, definitely where you cannot have any testing capacity, but please make sure that you take the same sample and send it to the reference lab for further analysis. That's what I wanted to say.
Okay, thank you very much. That's a great information. And Dr. Pokuta, do you want to add something? Dr. Pokuta, Elise Pokuta, voudrez-vous ajouter quelque chose, s'il vous plaît?
Principalement sur la question du test rapide ou le diagnostic du mpox. Bon, jusque-là, nous, principalement au laboratoire, nous n'avons pas encore reçu un test rapide efficace, je dirais. Bon, les recherches sont encore en cours, mais jusque-là, les tests que nous avons eu à évaluer n'ont pas donné des résultats concluants. Donc, jusque-là, on n'a pas encore déployé des tests rapides au niveau des provinces. On se contente de la PCR et je crois que bientôt, le pays pourra avoir aussi des cartouches et le Gène Expert qui est quand même moins coûteux et plus facile que la PCR normale, conventionnelle. Et je crois qu'avec les Gènes Experts, on pourra résoudre une partie du problème au pays. Merci. C'est ce que j'avais à dire.
Ouais, ok, merci beaucoup. Bon, c'est promettant. Ça veut dire il y a des progrès qui sont en train d'être faits. C'est vrai, pour l'utilisation des tests, il faut toujours l'évaluation de ces tests-là. Donc, une fois qu'on évalue les tests, on connaît les caractéristiques de ces tests, on pourra bien conseiller. Bon, ce n'est pas exclu, certainement. Mais si l'auteur, docteur, qui a posé la question, et docteur, il serait très bien aussi, ça c'est docteur Alain, si vous avez des informations, des évidences sur l'utilisation de ces tests-là aussi, vous pouvez partager avec l'audience, surtout en nous donnant les caractéristiques et dire que vraiment ça marche beaucoup parce que le but, c'est vraiment dans les interventions qui seront possibles au niveau sur tout le territoire. Ouais. Donc maintenant, on va passer à d'autres questions. Les questions qui sont adressées à Dr. Thomas et Dr. Félix sur la surveillance. Over to you,
Yeah,
Dr. Thomas. Thank you.
Thank you. Thank you. Let me just throw a few lights. I'm quite sure Dr. Tibley will also help with the World Health question. But it's important to note that the first thing is mpox is a zoonotic disease. That implies that countries must be encouraged to utilize a One Health approach to not just the response, but the investigation component of it. Because if the exposure of transmission of a case could be from animal to human, there is a need to be able to have a joint field examination or investigation for such a case. Liberia has huge forested communities, and so it's just important that you are encouraged to do a joint case investigation. We could look at working on the existing template with our animal health colleagues to see if we can have a much more robust, integrated, form. Should you suspect an animal exposure, then that component can be applied. So it is something that is doable, and we can begin working on that. Reference to the number of countries that have recorded cases, as the mpox focal pressing at Afro here, Liberia has recorded cases this year. DRC account for more than 85% of the cases we've recorded, even from epi week 1 to 16 at the moment. Congo has recorded cases, Cameroon, Central African Republic, and Nigeria. These are the countries that we've so far recorded confirmed cases for in 2024. But additionally, Ghana, a couple of other countries, 2023 and 2022, more than 10, 15 African countries have recorded cases. So that's why it is. And so far, DRC has both sequencing facility and PCR. All of these countries have PCR facilities to conduct, except for Liberia, we're still not too sure yet. It is my understanding that our laboratory colleagues should be heading to Liberia, or if they are not there already, to support them with sequencing capacity. They have the sequencing equipment, but they just need some other additional support. With Congo, there is a research team there that is supporting them. I don't know how far that has gone with ensuring that they have sequencing capacity, but I think our laboratory colleagues can speak to that. But in terms of PCR, all of these countries have the capacity to conduct PCR. The only challenge you might find in DRC, for instance, right now, what we have less than 15% of the cases, the suspected cases being tested. That is just to speak to the distribution of the testing facilities. They have less testing facilities compared to the number of sites or the number of provinces that are being infected. So there is a need to additionally support countries like DRC to increase the testing capacity in other regions. Thank you very much. In reference to the posters, yes, if you check online, there are posters that WHO have developed that you can adopt. Furthermore, if there is any need for us to look at country-specific need in reference to posters, we could talk with the RCCE colleagues to see what additional support can be provided. Thank you.
Yes, thank you very much, Dr. Thomas. You addressed the question very well. And in terms for case investigation form, indeed, you can add the component for animal. For example, if suspected case has been in contact with animal. We have done that during Ebola outbreak for those who were around. It was a long form, and you could see it as well. As you know, for mpox, sporadic cases were always linked to kind of animal sources. But when it comes to human, now the human behavior and all this, especially something related to sex and food, you know that is going all over the place. And it's a control need, really social science component of it. So for One Health, yes. In Liberia, if you remember, a couple of weeks ago, we conducted joint risk assessment, which is to bring all the sector together to assess the risk and to develop mitigation measures together. So indeed, your question is valid. And yes, we have had it in the past, but to reduce the form, we remove it to simplify, but we can add animal component with great pleasure. For the poster and video as well, we have an online training, I think, for those colleagues who took it. And you can even have a certificate for taking that course, which can help you as well in case someone say, if you have knowledge and it's not an academic one, but it shows that you took part, you have that knowledge. You can go online, and my colleague Daniel and Mohammed and Amarachi, they can post the link. And I posted as well few poster with lot of description. But otherwise, yes, we agree with you and Dr. Somo. And if you want to convince the community, it is always good to have material in hand, to have a tool. And with Dr. Thomas and the team as well, and we plan to bring participatory One Health disease detection tool. It is a One Health toolkit, and it will help in terms of having this platform and having the different sector communicating. That it is on pipeline. Otherwise, the ideas are described very well, some of these concepts as well. There was a question about vaccine and saying that most cases are under 15. That was given by Dr. Sumo and from Liberia again, because he was at the meeting. Then his question was why we can't vaccinate all under 15. Now, all under 15 in a high-risk area or all under 15 in Africa. Of course, that will be really a lot of money, a lot of resources. It is worth doing it and in a high-risk area. And but the vaccine, the doses, I think it was not enough, and there is an approval procedure as well. But I let colleague to address it. Okay, over to you, Dr. Felix, if you want to pop on that, and Dr. Thomas and Dr. Pukaka as well, and Rachel, if you want to address them. And we have Adesola here with us, certainly, and Rosamond, if she is connected. I think if you go to previous presentation, Rosamond mentioned well about vaccine. I was involved in it, and I know that you have a different vaccine available now, and you know US CDC was even conducting a trial in DRC, and vaccine was used, and it has some effectiveness, you can call it, and efficacy as well. And but having enough dose to vaccinate all under 15 in a high-risk area and complying to ethical, everyone deserves it, will be a challenge. Otherwise, it is a good idea because, in fact, vaccine is a one health tool, especially when the disease is a zoonotic. You can take that from me. You can say I mentioned it. You will not get it wrong. And if you want, I can elaborate on that in another presentation. Thank you very much. Okay, over to you, panelists, if you want to complete. Thank you. Richard?
Thank you very much. I think there's a lot of interest. I'd like to just make comments in terms of the ones asking if they do not have PCR capacity in their countries, what they should do. We'd recommend that you reach out to the WHO country office and we'll get the request at the regional level where we can support you if it's a matter of training. But one thing to note is during COVID-19 pandemic, a lot of PCR capacity was built in countries. So just let us know what kind of capacity you need, then we can see how to support. Then as far as bioperfectors for mpox detection, I cannot comment. Has this been submitted already for validation through the WHO emergency use listing? If that has been done, then probably it's a matter of waiting to get your results. So if it has not, then at that point, we cannot exactly validate it, but you can use it in your own capacity and try it out with positive and negative samples and determine for your specific needs if this is working for you. So I think there's a lot of interest in monkeypox and I think mpox, and I think the important thing is, as one of the participants said, is continue testing so that you can know what you have in country, just to be able to trace and detect and then be able to treat or contain the disease. So we are very encouraged. We are open to support even after this through mailing, and we'll just be happy to give our input as we go along. Thank you.
Rachel, thank you very much. Now I can see Professor Dimi Ogwena with us, and I'm very pleased. He's one of the guru in mpox. He was even at the IHR committee, and it will be really, it is timely, and so you are connected. Maybe before closing, probably you take the floor and you put your camera as well. Professor Dimi Ogwena, over to you, and you can address anything you would like. Yeah, Professor Ogwena, you are connected. Is muted. Okay, Mohamed, please. Mohamed.
Yes, Dr. Chipley.
Okay, fantastic. And you have the floor now for the question, and you can reassure participants that the presentation will be shared and whatever you want to add. Yes. I can see two.
Yes, we have two raised hands.
Okay.
Dr. Shinwe Ubru, please take the floor. Activate your microphone. Dr. Fazine Sylvie, could you please take the floor? Activate your microphone.
Normalement, moi, c'était une erreur. Hein? Je n'ai pas une question. Je vais juste baisser la main. Merci.
OK. Dr. Hassan Saware.
Yes, thank you very much. And I just want to make some comments with regards what they said about the posters for my Liberian counterpart. And you did mention that there are a lot of posters on the WHO website with regards to monkeypox. But I also want to draw your attention to the last Ebola we had in the country. And most of these posters which we downloaded from the internet, which we are using for our cases, we also realize that some of the signs and symptoms on those posters were quite different from the actual cases we are having. And also similar things happens with regards to COVID-19. Some of the signs and symptoms which we are seeing on the internet with regards to the COVID and that of the Ebola, we are quite different from the actual cases we are having on the ground. So probably I will suggest that in as much as they are also registered a confirmed case, we also need to know what were some of the signs and symptoms. Are they of the same with those on the internet? Because this is where sometimes we have problems with the community. Once we project these posters to them and we tell them that this is the signs and symptoms of monkeypox or Ebola or COVID, if they are not able to see those signs and symptoms, including the frontline health workers, if they are not able to see those signs and symptoms, that is how we start to miss cases. So probably WHO also has to look into this keenly and then try to see that how best we can harmonize those posters. That's my concern, and thank you.
Okay, thank you very much, Dr. Hassan Soare. Yes, 100% agree with you, and that's why, because Professor Dimi, he has some connection. Professor Dimi Ogena, for those who don't really is well known, and he could talk a little bit about it because we saw his publication and presentation, and yes. Definitely, it is context dependent, and human nature, by human nature, we are immunological different. So the disease manifestation, clinical manifestation, might differ based on several characteristics, even environmental context. All will play a role. We always at the WHO and other with other partners, we always encourage to adapt to the context. You can have those pictures and poster as general background knowledge, but when it comes to your own context, now you need to put that into that context. For example, at your level, you will know these are the different manifestations, which is good. Then in our context, these are, we have seen mpox like this clinical manifestation. And even if you go to the community level, we are all part of community, then you can explain this one. I can give you a practical example, which I used to do in the field when it comes to polio. I used to show the different clinical signs and different contexts as well. So no one is exempted to it if you don't take precaution. Imagine you show a president which was disabled by by polio, then you go to the village, you show to them that even this, so it makes an impact. But it depends on the way you put it into the way you use it. Because you see, information, there is information, acceptability, and use of it, and understanding it, which all come under health literacy umbrella. So it's very important. You gave very important question. Okay, really, thank you very much for this question. Whatever poster you take, you adapt to the context. It is like IDSR guideline, as Dr. Thomas mentioned. It is adapted at national level as well, so we can be on the same path. But WHO and partners, they will help you to do that. Okay, thank you very much. Okay, any other question, Mohamed? Hand up or not? Victoire Urban, I can see your hand up before closing. Over to you, Victoire.
Oui.
Dr. Victoire.
Attendez. Est-ce que vous m'entendez? Merci pour la parole.
On vous entend, mais parlez plus fort, hein.
Oui, oui. Ma question est celle-ci. Je voudrais savoir si il n'y aurait pas une hésitation à la vaccination contre la mpox qui serait liée à la vaccination contre la COVID-19. Est-ce que la vaccination contre la COVID-19, l'hésitation contre la vaccination de la COVID-19 n'impacterait pas sur la vaccination contre la mpox?
Okay.
Merci.
Thank you very much. Yeah, Dr. Victor Urban, and a colleague can now can step in, but I will take that question. Yes, it is an important issue, and the question is very valid as well, because we are seeing a lot now, especially on COVID vaccine, but we can use the negative aspect of the vaccine. We can take opportunity and use that opportunity as well to boost the vaccination for other disease, to boost the vaccine uptake for other disease, because no one can ignore the role played by vaccination, by immunization as well. No one can ignore it. That's a fact. So, for example, someone may say, well, COVID vaccine, they mislead us. They misled us to take COVID vaccine. That's the naive interpretation. But on the other hand, the vaccine plays a crucial role in terms of reducing the transmission or the clinical manifestation of it. Myself, I took the vaccine 3 times. But when I had COVID, it was not like a clinical sign we have seen in the past. So it is always important. So you can emphasize on it, but you need to do your homework. Doing your homework is knowing the disease, knowing the role of the vaccine, and how many people have taken, the effectiveness of it, or so you can use those ones to boost the vaccine uptake, because it is the benefit, the economic benefit, and the health benefit which play crucial role. So it depends the skill you have. And that's why we encourage everyone to look at those aspects, how to communicate. Communication is very important. And to listen and to act upon it. So because you will have several other vaccines. So if, imagine, for example, we refuse the vaccine, all vaccine based on a single or isolated cases, it will be a really disaster for the world, the entire world, the entire humanity. Because immunologically, we are different. Some people, even if they didn't take the vaccine, they might develop the outcome you have seen. But the time probably they took the vaccine, it could be coincidental. How do you know? You have to look at the data. You have to have that ability to synthesize the data, to make sense of it. And that interpretation is a skill you need to have. Did I address your concern?
Oui, merci beaucoup.
Okay.
Oui, merci beaucoup. Merci beaucoup. Vous avez bien répondu à la préoccupation.
Okay, thank you very much. And we all need to work together and to work with community. And that's why it is very important when you do even the vaccine trial, you need to have community on board, because they are the key stakeholder. They are the beneficiary. But when it comes to vaccine, we all are the beneficiary of it. So we need to work together to understand it and why we take it, and the next step, how we need to be vigilant about the consequences as well. Okay, thank you very much. Yeah. Okay, colleague.
Okay, Dr. Tieblé,
Yeah?
I think it's time to wrap up.
Okay, fantastic. That's why I was I was waiting for. Yeah, you gave me the green light to move on. Really, we thank you all for attending this webinar, and we have a further webinar coming, further series, and where we will hear from eminent speakers as well. And please join us to those webinars. But all material will be shared with you, and guidelines and technical notes and on this presentation. We thank our interpreters as well. We can see them, Maria, Texa, and a colleague are connected. And we have Eileen as well, and Amarachi and Mohamed for the hard work they've been doing. And Daniel and colleague as well. Constant, I didn't forget about you. Thank you very much for interpretation, and even colleague who speak Portuguese, they join us, but all your questions will be addressed. Thank you very much, colleague, panelists, and you have done an excellent job. Let's continue to work with countries, with our colleague, because we come from countries as well, and the role can be swapped, but this is for good purpose, for unity. Okay, thank you very much. Congratulations to all of you. Thank you. See you next time.
Thank you.
Thank you.